Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing a very important topic in the connective tissue disorders, that is Wilson's disease. So, if you see the definition of Wilson's, it is also called as the hepatolenticular degeneration, right? So, it is also called that is liver lenticular degeneration. Now, in these patients with the Wilson's, it is an inherited disorder. And what type of inheritance is this? It is an autosomal recessive type of inheritance, right? And this is usually seen in persons between the age group of 3 and 55 years of age, okay? So, age group at which you will see is 3 and 55 years of age. And this particular condition, that is Wilson's, it is characterized by excessive deposition of copper in liver and as well as brain, okay? Excessive deposition of copper in liver and as well as brain, okay. So, that is what is your Wilson's disease. And not only the liver and brain, there are multiple organs which are being affected in the Wilson's, which I will be discussing in detail. So, I said you it is an autosomal recessive type of inheritance and it is mainly due to genetic defect. So, genetic defect in Wilson's disease is that the gene abnormality, it is localized on chromosome 13, okay. The gene which is abnormal, it is localized on chromosome 13. Okay, and that particular gene, it is present on chromosome 13 and the gene is ATP7B gene, right? The gene is ATP7B gene. So, this ATP7B gene, it has been shown to affect a copper transporting ATP, that is adenosine triphosphate, in the liver. So, because of this gene mutation, what exactly happens is copper transporting ATP in the liver gets affected. Right, copper transporting ATP in the liver gets affected, and because of this there will be excessive copper accumulation in the liver and there will be oxidative damage of hepatic mitochondria, okay. So, because of this abnormality there is excessive copper accumulation in the liver and this particular copper, it also causes oxidative damage to hepatic mitochondria. Okay. So, this is the genetic defect in patients with the Wilson's. Now, apart from that, let me tell you, there is one more genetic abnormality in the Wilson's, that is, see, most patients are compound heterozygotes, that is, they carry two different mutations, and another mutation is H1069Q mutation. So, please remember, one of the very important gene which is being mutated is ATP7B, which is on chromosome 13. The other gene which is being defective is H1069, but this mutation, it accounts for only 37 to 63% of the disease alleles, and this is very common in population of Northern European descent, right? This is very common in population of Northern European descents. Now, let me discuss what are the major organs affected in Wilson's. One of the very important organ which is affected is liver and then followed by that brain, Okay. Now apart from that, what are the other organs which are affected? So the major organs which are affected is liver, then brain, cornea and kidney. Okay. So these are the other organs which are being affected in patients with the Wilson's. So in Wilson's, actually what is happening is, because of the gene mutation, there is excessive absorption of copper from the small intestine and decreased excretion of copper by the liver. Okay. So there is increased absorption of copper from small intestine and decreased excretion from the liver. Okay. And because of which there is excessive copper accumulation within the liver. Now let me just tell you what is a normal metabolism of copper in a normal person and what exactly happens in Wilson's. Let me discuss. So once the individual does the ingestion of the copper, I will tell you what are the copper containing food substances. I will be discussing that in treatment part. So once the individual does the ingestion of the copper, 40 to 60% of the copper, it is reabsorbed across the intestines. Okay. And this absorbed copper, it will bind with albumin and it is carried to the liver. And within the liver, there will be dissociation of copper. That means the albumin, it gets separated, right? There will be dissociation of copper in the liver. Now this particular copper, it is taken by the hepatocytes within the liver. So hepatocytes reuptakes the dissociated copper, right? The hepatocytes reuptakes the dissociated copper and incorporates them into the substance called ceruloplasmin, right? So it is the ceruloplasmin which incorporates the copper which is taken up by the hepatocytes. Okay. And one molecule of ceruloplasmin one molecule of ceruloplasmin, it incorporates almost 6 copper atoms, it incorporates almost 6 copper atoms. And this ceruloplasmin containing 6 copper atoms, it is secreted into the plasma. Now after the ceruloplasmin getting secreted into the plasma, this senescent, that means old or dead ceruloplasmin, it is endocytosed by the hepatocytes, it is endocytosed by the hepatocytes and degraded within the lysosomes, degraded within the lysosomes. So that ceruloplasmin, it gets degradation within the lysosomes along with the copper atoms. Thereby you don't have the excess copper in a normal individual. But what happens in Wilson's disease, what is the basic defect in Wilson's? In Wilson's, there is reduced incorporation of copper in ceruloplasmin. So why there is reduced incorporation of copper in ceruloplasmin? Because the ceruloplasmin levels, they are reduced, ceruloplasmin levels, they are reduced in patients with the Wilson's. Okay. So there is reduced incorporation of copper in ceruloplasmin. Okay. Because there is reduced incorporation of copper in ceruloplasmin, there is reduced excretion of the biliary copper. So where will the copper get accumulated now? There will be increased copper in the liver itself. So copper accumulates in the hepatocytes, resulting in the liver damage, resulting in liver damage. Okay. And what will be the form of liver damage? The form of liver damage will be in the form of cirrhosis of liver. Liver damage will be in the form of cirrhosis of liver. So at one point of time, the liver cells, they get saturated with copper. Once the liver cells, they get saturated with copper, then the copper, it starts spilling into the plasma. Okay. So the copper, it is spilled in the plasma, right? And the spilled copper in the plasma, it gets deposited in various organs, right? It gets deposited in various organs in the body, and thereby the clinical features of the Wilson's can be seen. So that is about the copper metabolism in Wilson's disease. So what is the basic defect? The basic defect is decrease in the ceruloplasmin levels. Now because of decrease in ceruloplasmin levels, there is reduced incorporation of copper in the ceruloplasmin, right? Now let me discuss what will be that hepatic manifestations and what will be that multi-organ system being involved, right? The copper, it gets spilled into the plasma and it gets deposited in various organs in the body. Now accordingly, let me discuss the manifestations. So first, if you see the hepatic manifestations, the liver, it often bears the brunt of the injury in Wilson's disease, with hepatic changes ranging from relatively minor to massive damage. Okay, so in the liver there will be minor to massive damage. And what are the changes that you will have in the liver? That includes, number one, fatty change. Fatty change will be the minor change. Subsequently, the individual will have progression to the development of acute hepatitis, then chronic hepatitis, then followed by that, subsequently the individual will also develop cirrhosis of liver. Okay, so these will be the changes. The fatty change will be the minor change and the massive damage will be cirrhosis, or there can be massive liver necrosis. Right, there will be massive liver necrosis, and this massive liver necrosis, we call this as acute fulminant hepatitis. Okay, so these will be the massive damage, and let me tell you, all forms of hepatitis are seen in Wilson's disease. Right, even the chronic active hepatitis is also seen in patients with the Wilson's. So these are the changes within the liver, starting from the fatty change up to the cirrhosis and massive liver necrosis. Then you take the CNS manifestations. In brain, see, what did I tell you in the pathogenesis? The spilled copper, it goes and gets deposited in various parts of the body, and this copper is being transported even to the brain. So in brain, the toxic injury primarily affects the basal ganglia, right? The toxic injury primarily affects the basal ganglia, and within the basal ganglia, you know the parts we have like caudate nucleus, putamen, substantia nigra, subthalamic nucleus of Lice. Okay, so these are the various parts of your basal ganglia, but particularly which part of the basal ganglia gets affected is the putamen. Particularly the putamen, which demonstrates the atrophy and as well as cavitation. Okay. Now, because of the involvement of the basal ganglia, there is development of the extrapyramidal symptoms. Right? Because of the development of basal ganglia, there will be development of extrapyramidal symptoms. And what are these extrapyramidal symptoms? That includes dystonia, right, where there is abnormal tone. There will be incoordination, and there can be development of, right, there can be development of tremor, and the bulbar manifestations in the form of dysphagia, where there is difficulty in swallowing. There will be also dysarthria, right, where there is difficulty in articulation of the speech, and there will be also development of chorea. So chorea is the involuntary movements within the extremities. So these are the CNS manifestations that are seen because of the involvement of the basal ganglia, right. Now apart from these manifestations, right, there is also development of the memory loss, right, and there will be also development of migraine headaches, right, and even the seizures. So these are the other CNS manifestations, and these patients, they have difficulty in concentrating on tasks, but cognition is usually not impaired, okay. So cognition is intact, right, cognition is intact, but these individuals, let me tell you, they have difficulty in concentrating on tasks, okay. Remember, sensory abnormalities, right, this is a very important point. Sensory abnormalities and muscular weakness, they are not seen in patients with the Wilson's, right. Only the individual will have motor manifestations related to your CNS involvement, but never the sensory involvement. This is a very, very important point. Next, followed by that, what will be the psychiatric manifestations? So there is history of behavioral disturbances within 5 years of onset of the disease, right. So there is history of behavioral disturbances, and this history of behavioral disturbances will be there within 5 years of onset of the disease, right, within 5 years of onset of the disease, right. And these psychiatric features, they are diverse and include loss of emotional control, right. So there is also loss of the emotional control, okay. And what will be the features of loss of emotional control? That includes temper tantrums and crying bouts, right, temper tantrums and the crying bouts. So these will be the manifestations due to loss of the emotional control. And apart from that, the other psychiatric manifestations include depression, and there will be also loss of sexual inhibition, right, loss of sexual inhibition, and these individuals, they will have hyperactivity, okay. So this is about the psychiatric manifestations that you will have in patients with the Wilson's disease. Then followed by the ocular manifestations. So if you take the ocular manifestations in patients with the Wilson's, there is brownish Kayser-Fleischer ring at the rim of the cornea, right. So I'll just show you the image also. This KF ring, it is present in the cornea, and in which layer of the cornea? That is within the Descemet's membrane. Right, that is within the Descemet's membrane of the cornea. So let me show you that image. Yes, so this is the brownish cave ring at the rim of the cornea in patients with the Wilson's disease. Now, apart from this, let me tell you, we have few more ocular manifestations apart from the cave ring. Apart from the cave ring, few more ocular manifestations will be in the form of cataract, and that will be sunflower cataract. Okay, so these are the ocular manifestations. Then, what will be the hematological manifestations in patients with the Wilson's? So, hematological manifestations will be in the form of the hemolytic anemia. Right, that will be in the form of the hemolytic anemia. So, in severe hepatic failure, hemolytic anemias may occur because large amounts of copper are released. Right, large amounts of copper are released in patients with severe hepatic failure, and that will be responsible for the development of the hemolytic anemia. Okay, so now please remember here, the association of hemolysis the association of hemolysis and liver disease, association of hemolysis and liver disease makes the Wilson's disease the likely diagnosis. This makes the Wilson's disease the likely diagnosis. And let me tell you, the type of hemolytic anemia that you will have in these individuals is Coombs negative hemolytic anemia. Coombs negative hemolytic anemia. So, this will be the hematological manifestations in patients with the Wilson's disease. Now, what are the other manifestations? The other manifestations, there will be renal impairment in these individuals, and there will be urinary excretion of the glucose. So, this urinary excretion of glucose, it is mainly due to impairment of the proximal convoluted tubule, and not only that, there will be urinary excretion of the phosphates. And there is also urinary excretion of the amino acids. And there will be urinary excretion of urate. Okay, and these patients, they also develop renal tubular acidosis. In what type of renal tubular acidosis? Actually, renal tubular acidosis, we have three types, that is type 1, type 2 and type 4. And the type of renal tubular acidosis these individuals will develop is type 2 renal tubular acidosis, wherein the abnormality is at the level of the proximal convoluted tubule. So, these are the other manifestations. So, to summarize the organs which are affected, liver is the very important organ which is being affected, and that will be in the form of the hepatitis or cirrhosis of liver, CNS involvement where there is involvement of the basal ganglia, and the other manifestations will be in the form of memory loss, headache and migraine. And even seizures are also very common. Sensory manifestations will never be there, and even muscular tenderness or muscular pain will not be there. And psychiatric manifestations will be in the form of the behavioral disturbances, and these individuals, they also have the loss of emotional control. The individual will be depressed, hyperactive, and there is also loss of sexual inhibition. The ocular manifestations will be in the form of cave ring, and there will be also the sunflower cataract. And hematological manifestation will be in the form of hemolytic anemia, that is Coombs negative hemolytic anemia, and there is urinary excretion of glucose, phosphate, amino acids, urates and renal tubular acidosis will be there. Now, let me tell you some of the most often asked features of the Wilson's disease. The question is, what will be the most common presentation of the Wilson's? Most common presentation of Wilson's in acute or chronic liver disease is that it will cause all the types of hepatitis. Okay, so hepatitis or hepatic manifestations, that will be the most common presentation of Wilson's. And if you take the chronicity in the Wilson's, even there will be development of chronic active hepatitis. Right, chronic active hepatitis. And CNS manifestations, if you see, the CNS manifestations will be in the form of the extrapyramidal features, that is due to involvement of the basal ganglia. And these individuals, they also have psychiatric manifestations, right, and that will be a behavioral alteration, and there will be frank psychosis, okay. And sensory symptoms, let me tell you, they are never present in patients with the Wilson's disease. And if you take the type of anemia in this individual, it will be hemolytic anemia. And what type of hemolytic anemia is this? It is Coombs negative hemolytic anemia, right? And what makes the diagnosis of Wilson's disease likely? The presence of the liver disease and the hemolytic manifestations, right, that is hemolytic anemia, that makes the diagnosis most likely. So what type of hemolytic anemia? It is the Coombs negative hemolytic anemia, right. So the diagnosis of the Wilson's is established in patients with low serum ceruloplasmin levels. Right, low serum ceruloplasmin levels. Number 2, presence of the KF ring, right. Number 3, elevated urinary copper excretion. Right, elevated urinary copper excretion. So the diagnosis of the Wilson's is established based on these 3 important parameters, right, and additional testing is required in patients with indeterminate results, right. And what is that additional testing which is required? You need to test for the serum copper levels, and next important investigation is the liver biopsy. So in the liver biopsy, you have to look for the presence of copper. So liver copper, that involves liver biopsy to determine the hepatic concentration and to look for the histological changes within the liver, and the genetic testing. So genetic testing, if you see, right, genetic testing, you have to look for the mutation of the gene, that is ATP7B, which is on chromosome 13, right. Now let me just give you the normal values and what will be the values in Wilson's. So you take the normal serum ceruloplasmin levels. Normal serum ceruloplasmin levels is 18 to 35 milligrams per deciliter. Right, 18 to 35 milligrams per deciliter. And in Wilson's, what will happen? Right, it is low in almost 85% of patients. And you take the KF ring. Normally the KF ring is absent, right, normally the KF ring is absent. But in patients with Wilson's, particularly in case of the neurological Wilson's, okay, so it is present in almost 99% of patients, right, present in almost 99% of patients, right. And if neurological or psychiatric symptoms are present, it is almost like 99% of patients, they have the KF ring. But if the individual is having only the hepatic manifestations, right, if the individual is having only hepatic manifestations, or the individual has presented to you in pre-symptomatic state, or you have diagnosed Wilson's in pre-symptomatic state, then the presence of KF ring is seen only in 30 to 35% of patients. So this is a very important point. See, many of you are under the impression that Wilson's means there should be a KF ring. It is not like that. Only in case of neurological or psychiatric symptoms developed, in 99% of individuals you will have the KF ring. But if the patient is presenting only with hepatic manifestations, or you have diagnosed Wilson's in pre-symptomatic state, then it is present in 30 to 35% of patients. Okay. Then what happens to your 24-hour urinary copper? 24-hour urinary copper, the normal value is 0.3 to 0.8 micromoles. Right, 0.3 to 0.8 micromoles. Whereas in Wilson's, what will happen? Urinary copper excretion is increased. Right, urinary copper excretion is increased, right? And how much will be? Normal value is like 0.3 to 0.8 micromoles. But here, the urinary copper which is excreted is more than 1.6 micromoles, right? In symptomatic patients, right, in symptomatic patients, the urinary copper excretion will be more than 1.6 micromoles. But in pre-symptomatic patients, the urinary copper which will be excreted is 0.9 to 1.6 micromoles. This is the quantity which is being excreted in pre-symptomatic patients. Right, in pre-symptomatic patients. Okay. Then you take about the liver copper. When you do a biopsy, right, and what will be the quantity of the liver copper, right? The normal value of the liver copper is around 0.3 to 0.8 micromoles per gram, right? Micromoles per gram. This will be the quantity of the liver copper, right? And in case of Wilson's, the liver copper is increased, right? And how much is that? It is increased. It is increased up to more than 3.1 micromoles per gram. Okay. So that will be the liver copper in Wilson's. And you take the haplotype analysis, right? And if you take the haplotype analysis in a normal individual, 0 matches, right? In the sense, in a normal individual, right, it is 0 matches. But here in Wilson's, you have 2 different alleles which can cause the Wilson's disease, right? And overall, what is the gold standard for diagnosis of the Wilson's? It is the liver biopsy with quantitative copper assay. That will be the gold standard, right? And how much will be that quantitative copper? The normal liver copper is 0.3 to 0.8 micromoles per grams. But here in case of Wilson's, it will be more than 3.1 micromoles per grams. Okay, and that will be the gold standard. Now let me discuss the treatment in Wilson's. So now let me discuss the treatment of the Wilson's disease. The important strategy or the important principle in the treatment is that early treatment is the one which will cause the removal of the excess copper before it can produce the hepatic or the neurological damage. Okay. So the essential of the treatment of the Wilson's is that early treatment this will cause the removal of copper before it can produce the hepatic or neurological damage. And not only that, you need to restrict the food containing the copper. And what are those foods containing copper? Okay, so Food containing copper, it includes shellfish, number 1, right, the organic foods, then nuts contain the copper, mushroom and chocolates. So these are the food substances containing copper. So these food substances have to be restricted in individuals suffering with the Wilson's disease. Then you need to give the copper chelating agents. And what is that particular copper chelating agent? That is D-penicillamine. So if you see the dosage of the D-penicillamine, right, the dose is 0.75 to 2 grams per day. Right, 0.75 to 2 grams per day, and this has to be given in divided doses, and this has to be taken 1 hour before or 2 hours after the food. So this has to be given 1 hour before or 2 hours after taking the food. So this should be the dosage of the D-penicillamine, and this is considered as the drug of choice, and it also enhances the urinary excretion of the chelated copper. Okay, so this is considered as drug of choice, and it also enhances urinary excretion of urinary excretion of the chelated copper. But whenever you are giving this D-penicillamine, along with D-penicillamine, you also need to give oral pyridoxine. And the dosage of this oral pyridoxine is 50 milligrams per week. Right, the dosage of oral pyridoxine is 50 milligrams per week, and that is added because the D-penicillamine, it is an anti-metabolite of this vitamin. Okay, so D-penicillamine it is an anti-metabolite of pyridoxine. Okay, so that is about your D-penicillamine, and this D-penicillamine, it is also associated with certain adverse effects, and the adverse effects of D-penicillamine includes gastrointestinal intolerance, right. Number 2, it can cause the hypersensitivity reactions, right. Number 3, it can cause autoimmune reactions, right, and there will be development of nephrotoxicity and bone marrow toxicity. Okay, so these are the adverse effects of the D-penicillamine. Now, after this D-penicillamine, another important drug is the trientine. Now, let me tell you what are the indications of trientine. See, for suppose if D-penicillamine treatment cannot be tolerated, like because the adverse effects of D-penicillamine is gastrointestinal intolerance, hypersensitivity reactions, autoimmune reactions, nephrotoxicity or bone marrow toxicity. If because of these adverse effects, if D-penicillamine cannot be tolerated, then you need to consider the usage of the trientine, right? And what is the dosage of this trientine? That is 250 to 500 milligrams 3 times a day. right, 250 to 500 milligrams 3 times a day. And this trientine, it is a copper chelating agent, and efficacy wise it is as effective as the D-penicillamine, but with a lower rate of adverse effects. So even if you take the adverse effects, there is lower rate of the adverse effects. And this trientine, it is increasingly used as the first line agent. Right, it is increasingly being used as the first line agent, although its cost has been exorbitant, right? It is little expensive drug. That is the only disadvantage of this particular trientine. Otherwise, the efficacy wise, it is as effective as the D-penicillamine. Okay. Now, what should be the doses of penicillamine and as well as trientine in pregnancy? The doses of penicillamine and trientine should be reduced, right, should be reduced in pregnancy. Then another important formulation is the zinc acetate or zinc gluconate. The oral formulation of zinc acetate or zinc gluconate, and these drugs or these zinc formulations interfere with the intestinal absorption of copper, right? And what should be the dosage of these particular zinc formulations? That is 50 milligrams 3 times a day. These particular formulations, they will interfere with the intestinal absorption of copper. Right, they interfere with the intestinal absorption of copper. And not only that, this oral zinc acetate and as well as zinc gluconate, it will also promote the fecal copper excretion. So because it is interfering with the intestinal absorption of copper, so fecal excretion of the copper is increased, right? It promotes the fecal copper excretion, and this also has been used as the first line therapy in asymptomatic or the pregnant patients. Okay, so this has been used as first line therapy for asymptomatic and as well as the pregnant patients. And this is also used as the first line treatment those with neurological disease, and it is also used as maintenance therapy after decoppering with the chelating agent. Okay, so this is also the first line agent with neurological disease. Okay, now, and it is also used as maintenance therapy. Right, when will you use this as a maintenance therapy? After decoppering with a copper chelating agent. Okay, so this is about the zinc acetate or the zinc gluconate. But this zinc acetate is also associated with certain adverse effects. Now, what are the adverse effects of the zinc acetate? It causes the gastrointestinal effects, and because of this leads to discontinuation, and its long-term efficacy and safety have been questioned. Okay, so and these gastrointestinal disturbances, they are in the form of nausea and as well as vomiting. And not only that, this drug, it is also associated with increased risk of hepatotoxicity. Right, it is also associated with increased risk of hepatotoxicity. right? And in certain individuals, that is in normal persons, it can lead to copper deficiency. Right, it can cause copper deficiency even in the normal persons, right? So that is about the adverse effects of the zinc acetate, alright. Now we have discussed two copper chelating agents, one is your D-penicillamine and trientine, and your zinc formulations, they increase the gastrointestinal excretion of the copper. Basically they will reduce the gastrointestinal absorption and they will increase the fecal excretion of copper. And we have one more substance called as ammonium tetrathiomolybdate. See, this particular substance, it complexes copper in the intestinal tract, right? It will form a complex with copper in the gastrointestinal tract, okay? And this ammonium tetrathiomolybdate, it is a initial therapy for neurological Wilson's. It has been shown as the initial therapy for neurological Wilson's disease, okay. Now followed by that, let me tell you, we have one more isomer of your tetrathiomolybdate, that is bischoline tetrathiomolybdate, right? That is bischoline tetrathiomolybdate. So this bischoline tetrathiomolybdate, it is chemically more stable and appears to be effective, right? It is chemically more stable and appears to be effective. So that is about your ammonium tetrathiomolybdate. Next, now the question comes, when is that you need to admit the patient? You have to admit the patient whenever the individual develops acute liver failure, right? You need to admit the patient if there is gastrointestinal bleeding. So gastrointestinal bleeding can be seen as a complication of cirrhosis of liver, right? So these individuals, they can develop portal hypertension, right? These individuals, they develop portal hypertension, and secondary to portal hypertension, there can be esophageal varices causing hematemesis, or there can be hemorrhoids wherein there can be melena or the blood within the feces, right? And you have to admit the patient when the individual develops stage 3 to 4 hepatic encephalopathy. Right, stage 3 to 4 hepatic encephalopathy, right? And hepatic encephalopathy is another important complication secondary to cirrhosis of liver. And if there is worsening kidney functions, right? If there is worsening kidney function, then also you need to admit the patient. And if there is development of severe hyponatremia, right? Because in patients with cirrhosis of liver, there can be dilutional hyponatremia. So when there is severe hyponatremia, even then you need to admit the patient. Then if there is profound hypoxia, you need to admit the patient, okay. So these are the indications for admitting the patient in clinical scenario of the Wilson's. Then how is that you need to treat this patient? For example, if the individual has developed acute liver failure, you can do plasmapheresis. So plasmapheresis, you can remove the copper, That is one modality of the treatment. Then exchange transfusion. And the other aspect of the treatment or alternative treatment is the hemofiltration or dialysis may be performed while awaiting for the liver transplantation, right? So these patients ultimately they require liver transplantation. Okay, so until the individual undergoes this particular liver transplantation, you need to do hemofiltration, or hemofiltration, or the dialysis has to be done. So this is about the treatment of the acute liver cell failure, right? And these patients with Wilson's, please remember, they require lifelong therapy, right? They require lifelong therapy. Now, we have discussed many treatment options like D-penicillamine, trientine, zinc, ammonium tetrathiomolybdate. Let me just summarize everything. So, for example, if the individual has initial hepatic manifestations, right, or if the individual is having hepatitis or cirrhosis without decompensation, in this scenario, you need to give zinc as a first choice, right? In this scenario, you need to give zinc as a first choice. Whereas, hepatitis or cirrhosis with decompensation, right? Hepatitis or cirrhosis with decompensation, in mild form, you need to give trientine and zinc, right? Whereas in case of moderate, it is the same, trientine and as well as the zinc. Whereas in severe form, you need to do the hepatic transplantation, right? You need to do the hepatic transplantation. This will be the first choice treatment. Then what will be the second choice? Like you take when the individual is having initial hepatic manifestations or hepatitis or cirrhosis without decompensation, the second choice drug will be trientine. Whereas when the individual is having hepatitis or cirrhosis with decompensation, then the second choice drug will be penicillamine and zinc. Right, D-penicillamine and zinc. That will be the alternative choice in case of the mild form of cirrhosis with decompensation. Whereas in moderate forms, the alternative choice will be hepatic transplantation, right? And in severe form, the alternative is trientine and zinc. Okay, so these are the second choice drugs, right? Or the alternative for these hepatic manifestations. And when the individual is having the neurological features, the initial choice will be tetrathiomolybdate, and the alternative is zinc, right? Tetrathiomolybdate and zinc. And what will be the second choice for neurological Wilson's or psychiatric manifestations? That is trientine and zinc. Okay, so that will be the second choice when the individual is having neurological Wilson's or psychiatric manifestations. Then what about the first line treatment as a maintenance therapy? First line treatment in pre-symptomatic therapy, first line treatment in pediatric Wilson's, first line treatment in pregnant women with Wilson's. In all of them, the first line treatment will be zinc. And the second drug or the second choice will be trientine. right? The second choice will be trientine. So this is about the first choice and as well as the second choice, the recommended anti-copper treatment for Wilson's in various groups of patients. Now, if you take the essentials of diagnosis, right, to summarize the entire Wilson's is an autosomal recessive disorder that usually occurs in persons under the age of 40 years. And excessive deposition of the copper will occur in the liver and as well as in the brain. And serum ceruloplasmin levels, it will be low, right? Serum ceruloplasmin levels will be low. And urinary excretion of copper and as well as the hepatic copper concentrations, they are very high. Okay, so that is about the essentials of diagnosis of the Wilson's. So, Wilson's, when can you come to a very close differential diagnosis? Hepatic manifestations and the presence of hemolytic anemia, right? A very important first differential diagnosis should be your Wilson's disease, right? So with this, I'll wind up this topic of Wilson's, and subsequently in the next session, I will be also discussing the multiple choice questions on the topic of Wilson's. Thank you very much.